This is an ECG of a 26-year-old woman who presents to her general practitioner's office with palpitations. She describes the palpitations as an intermittent pounding sensation in the anterior left lower chest, usually occurring in the evening, especially when she lays down to sleep. She is otherwise well and an active, healthy woman. Let's look at her ECG. We can start by examining the long rhythm strip at the bottom of the tracing, which is actually lead 2. We can see that there are P waves before every narrow QRS complex. In addition, there is a second morphology of QRS complex, which is wider and comes earlier than the expected QRS complex. These are premature ventricular contractions, or ventricular premature beats. Let's now go back and examine the P waves more closely. They are positive in lead 1 and in lead AVF, thus originating from the sinus node. The rate is about 100 beats per minute. We can see that the P waves are normal in the inferior leads and in lead V1, suggesting no evidence of left or right atrial enlargement. The PR interval is normal. The QRS axis is positive in lead 1 and positive in AVF, suggesting a leftward inferior axis, which is normal. Because the QRS complex is normal and sharp, there is no evidence of any intraventricular conduction delay. The voltage of the QRS in the limb leads and the precordial leads is normal, with a normal axis, and thus there is no left or right ventricular hypertrophy. Here, there is no evidence of any abnormal Q waves, and there is normal R wave progression from leads V1 to V3, suggesting no evidence of infarction. The ST segments are normal, and the T waves are positive in lead 1, AVF, and V2 to V6. Showing a normal pattern of repolarization. Overall, this ECG shows normal sinus rhythm with occasional premature ventricular beats. Otherwise, this is a normal tracing.